Hi, my name is Brian Yan. I'm an associate professor at Western University in London, Ontario, Canada. On behalf of my authors, I would like to thank Gastrointestinal Endoscopy Journal for inviting us to discuss our paper entitled The Reliability of Endoscopic Ultrasound Indices to Detect Inflammation in Ulcerative Colitis. This will soon be published in GIE. The treatment of ulcerative colitis has significantly changed in the past decade. No longer are we only aiming for symptomatic improvement alone, but our targets now include mucosal healing and, to push it even further, histologic healing. In the past, endoscopic ultrasound and transabdominal ultrasound have been used to assess the degree of inflammation in ulcerative colitis and to help prognosticate future relapse. One of the issues with all of the previous studies is that the reliability of the modality has not been fully examined. We therefore did our trial to assess the reliability of endoscopic ultrasound in a blinded prospective manner. If EUS can reliably identify inflammatory processes deep to the superficial mucosa, it may play a valuable role in trying to select certain therapies for patients, to prognosticate response to therapy, perhaps prognosticate relapse, and in the future, perhaps even identify those patients who can de-escalate therapy. There are a few points to our study which I'd like to discuss. The first is the methodology used in our trial. This was the most objective study for endoscopic ultrasound in ulcerative colitis to date. We used a system called Central Imaging Management System, or CIMS for short, developed by Robarts Clinical Trials here in London, Ontario, Canada. The system allows us to record entire videos for both endoscopy and endoscopic ultrasound to be uploaded onto a central server. The expert reviewers can then adjudicate the videos from anywhere in the world. The videos are de-identified and scrambled, and this allows for the most objective means to determine the intra- and inter-observer variability. What we found from our study is that the intra-observer variability is excellent. However, the inter-observer variability is only fair. This does show promise for endoscopic ultrasound as it demonstrates that the abnormalities found can be reproducible. We developed a new endoscopic ultrasound index for inflammation based on the previous indices to hopefully improve on the relatively poor inter-observer variability. This new index is easy to use, easy to learn, and hopefully will improve on the previous indices used. The next point I would like to discuss is a challenge on our thinking of ulcerative colitis as mucosal inflammation only. Our study, along with the previous EUS studies, transabdominal ultrasound studies, and pathological studies, demonstrate that subepithelial inflammation does occur. We see changes in regards to the bowel wall thickening, we see abnormalities between the different layers of the bowel wall, and we see increased vascular signal deep in the submucosa. What we don't know are what are the implications of each of these components. What weight do each of these components carry in regards to acute versus chronic inflammation? Which components change with therapy? How quickly do they change with therapy? And can each of these components individually used to determine the prognosis in regards to relapse? This brings us to the third and most exciting point, which is the personalization of care for patients with ulcerative colitis. Endoscopic ultrasound may provide valuable information to the clinician independent of the mucosal changes seen on endoscopy and histology alone. Depending on what's abnormal in EUS, one may be able to choose which class of medications is optimal for any given patient. This will become more important in the future when we have new medications with different mechanisms of action. On the flip side, EUS may also help determine which patients are literally in deep remission, and as such, select the appropriate patient for de-escalation of therapy. But we are not there yet. We have demonstrated in our study that the previous EUS indices of inflammation needed to be improved upon. In our study, we developed a new index, and we need to validate this new index in a new subset of patients. We need to determine if that the index is responsive to medical therapy. Once we have this completed, then we can develop the trials required to see whether or not EUS truly does improve patient care in ulcerative colitis. Thank you for watching. I hope it is stimulating in regards to our thoughts around ulcerative colitis and its future therapy. And again, thank you to gastrointestinal endoscopy for this unique opportunity.